Hi, and welcome to our Conceive Baby discussion today. Today we'll be talking about a topic that affects many couples. In fact, 1 in 3 pregnancies is affected by miscarriage. And perhaps precisely because it is so common, women are often told things like, these things happen, just take some time out and try again. But really there's a lot more to it than that. There really is a huge emotional and physical toll around miscarriage. And there's also a lot of, fear and trepidation around just trying again. There's a lot of questions around, why did it happen? How do I know it won't happen again? And how can I prevent it from happening again? Unfortunately, many couples are provided with few answers. So today we're really here to help bridge that gap, to really provide you with some tools to help you be proactive, to reduce your risk of miscarriage and increase your chances of a healthy pregnancy and a healthy baby. So firstly, for those who haven't joined us before, my name's Tasha Jennings, founder of Conceive Baby. I'm a naturopath, nutritionist, natural fertility specialist, and author of The Vitamins Guide and The Fertility Diet, as well as an expert contributor to major media publications such as The Age, The Herald Sun, Yahoo 7, New Idea, as well as other parenting and pregnancy websites. And as many of you who are part of the Conceive Baby community would know, I'm really passionate about helping couples conceive and carry healthy babies. And my aim for conceivebaby.com.au is to really bring together a team of specialists across all aspects of fertility and preconception health to provide you with qualified expert information to help you achieve your baby dreams. And today I'm thrilled to be speaking with a fabulous expert in this field, Angela Hywood. Angela is an experienced naturopathic clinician with over 20 years clinical experience. She runs a busy clinic in Perth in Western Australia, specialising in integrative endocrinology, women's health and fertility. And prior to her career in naturopathy, Angela studied at the School of Pharmacy at Curtin University of Technology. Angela practiced at the world-renowned Jocelyn Centre of Natural Fertility Management, Australia's first specialised practice in the area of preconception health and fertility management, and has really dedicated her career to fertility and women's health. And with her uniquely integrative approach, she's assisted many couples overcome their fertility obstacles and really fulfill their dreams of becoming parents. Angela has a passion for helping couples become parents and seeing their families thrive. She is a mother of 2 little ones herself, with children very similar ages to my own actually, at 2 years and 3.5 years, both of whom were carefully and consciously planned, and both of whom were conceived naturally after 40. Angela has also just spent the last 6 months writing a chapter in a medical textbook on miscarriage. And in addition to her practice and education roles, Angela is a well-known featured speaker at complementary and integrative medicine conferences internationally. And I know she's just flown in from one of those lectures in Sydney this morning, and I really appreciate her taking the time out of her busy schedule to be with us today. Welcome, Angela.
Thank you so much for having me join you today, Tasha, and thanks for everyone for joining in to listen. I'm really delighted to be here today to have this conversation about something that I'm, really incredibly passionate about, which is fertility in general, but it's, for me, I call it the prevention of heartbreak of babies that possibly could have been. And I guess this is really close to my heart because of my own mother, in her journey to have, my brother and I, she experienced 11 miscarriages on only 2 full-term pregnancies.
Wow.
So I kind of think it's my lot in life to maybe explore this and And certainly I was able to provide my mother in the end with kind of a lot of answers as to why that was her path. So it's close to my heart personally and very close to my heart professionally.
Yeah, look, I'm really thrilled to be speaking with you today because obviously, I mean, I wasn't aware of your personal background, but your professional background is so really enormous in this area, and particularly in miscarriage, and something that I think many women have experienced that don't get answers to. So I'm really thrilled to have you talking to us to provide some of those answers. So, and we mentioned like it is a very common occurrence, affecting about 1 in 3 pregnancies. But what is your experience with that, and then the occurrence of miscarriage in your practice?
Well, having just done 6 months of research in preparation for writing an extensive chapter on this topic, I was actually more shocked than ever to actually understand the international statistics around it. So basically, 15% of all clinically recognised pregnancies end in miscarriage. So that's the moment you get a positive on a pregnancy test, then, you know, automatically stats say there's a 15% chance of losing that baby. And that's not even looking at, you know, some of the other factors like, you know, age and, you know, health and wellness, etc. around that. They say that 30% of pregnancies are lost between conception and 6 weeks of that pregnancy mark. And one of the alarming statistics is approximately 70% of conceptions fail to get to live birth.
Wow, I think it's nice for people to know, and that they're not alone. I think we often don't talk enough about this, and I think you and I both discussed earlier, being in this industry, it often comes out of the woodwork that even, you know, reasonably close friends have never discussed this issue. So I think it's something that it's nice to know that you're not alone. There are other people in the same boat.
Absolutely. And, you know, I think that, you know, Australia, as it's a place that we live and have, you know, our community, there needs to be a lot more done in terms of emotional health and well-being for women who have suffered one or a number of miscarriages, because it is still very much the try again, I'm sure next time will be fine approach. And I say to women, you know, I work with them and counsel them with grief, because that's you know, precisely what it is. But I say to them, in my opinion, there is a lot that can be done. It's not just bad luck in a majority of cases. And the couples that I work with, because this is not just women's business, and this is also what we've got to get, you know, our generation's head around, is that the responsibility of fertility and having a family does not fall on the woman.
That's right.
It's about egg, it's about a sperm, and yes, it's about a healthy uterine environment as well. But essentially, when it comes to making babies and for the successful viability of that pregnancy resulting in the birth of a healthy child, you need 2 fundamental things. You need healthy sperm and you need healthy eggs.
Yeah.
So, you know, I give a lot of counsel around that men absolutely have to be involved in this journey with their partners to do investigation, do preparation, and be proactive around, you know, prevention of further miscarriages for that couple.
Yeah, it's good for the woman to know that we blame ourselves. I think it's a natural thing we do anyway.
Absolutely.
And you do hold a lot of that blame when in actual fact, it may not all be your fault. And if there are factors that are occurring within your body, many of them are fixable. And I'm glad to be talking about those today.
Absolutely. And, you know, it blows me away how much we actually do know and how much research is out there around about miscarriage. It's not the unknown anymore. However, one of the things that, you know, everyone who's a clinician, be it a medical doctor, be it a naturopath, or be it a fertility specialist, will know that generally miscarriages are not investigated until a couple have had numerous miscarriages and they're considered recurrent miscarriages. So generally investigation will start usually at miscarriage 3 rather than at miscarriage 1. And
that's a lot of heartache, and also people are starting their babies later, so you don't want to be at, you know, 35, 40 having those 3 miscarriages. So you're right, the earlier we can get onto this and be proactive, the better.
Absolutely. And one thing I want to, assure women out there that are older having their babies, like myself, and that was for no other reason that I didn't meet my Prince Charming until later in life. There is a high risk of miscarriage as you get older, but that's simply because that's our egg quality is worse. And you've had that miscarriage, you're getting on, you're 38 or 40, so it's egg quality problems. You'll just have to try again. Yet we know that there's so much we can do around supporting egg quality, reducing levels of toxicity, improving good quality nutrition, improving hormonal status. That go a long way to preparing for a healthy child. So, again, for older women, it is preventable as well. And the prevention is mainly in the investigations and in the preparation and being incredibly proactive and not letting it get to miscarriage 2 or 3 before some investigations take place.
Yeah, and seeing professionals like yourself earlier rather than later, and that you can see someone after the first miscarriage or even prior to. And I mean, absolutely. My passion is being the best mum starts well before birth. In fact, even before you were even conceived, you're creating, your baby's already there. When it's just a twinkle in your father's eye, I think that's, when you're already becoming a parent, that's when you're already carrying the DNA that it has the potential to become your future child. So really, the nourishing and the nurturing starts way back then, and that's what you can do to help you have a healthy pregnancy and healthy baby on both sides as well.
Absolutely. And what really excites me is since, the explosion of medicine and research in the field of genetics, we have learned so much more about, our genetic capacity and certain things called genetic polymorphisms that may give some, people in the community, unfortunately, higher risks of problems when it comes to their baby-making years. And one of them that I'm really passionate about is a genetic polymorphism that affects your folic acid metabolism. And that's called MTHFR. And I'm sure that's been discussed a lot in previous conversations.
Yeah.
This in itself is just a quantum piece of information, because I think unanimously every healthcare professional who works in the field of fertility agrees that, folate's been the golden child of nutrition for healthy babies for a very long time. So this link now to understand, do you carry this polymorphism? How does it affect what type of folic acid you need to be using for your individual genetic predisposition for preconception healthcare? So that's a gigantic leap, I think, in the direction of understanding miscarriage prevention. A simple genetic blood test, or it can even be a swab from the mouth, from both the mother and the father. This is information we need from maternal and paternal, because mum can carry 1 copy of a gene and dad can carry 1 copy, which potentially can give a child 2 copies. And if a baby is what we call homozygous, then that also increased risks of, clotting between mother and baby and reduction of blood supply between the mother and the child. And if that's severely impeded, then of course that baby can die in utero.
And we'll just, I guess, touch on that. The MTHFR is basically your ability to metabolize, I guess, the different forms of folate, and particularly the most common one, which I know a lot of specialists are still out there, and if folate isn't getting high enough, they just pump them with more and more and more folic acid, which we're now finding if you do carry that gene, you are not absorbing that synthetic folic acid properly. So as you were saying, there are other forms of folate now available that we need to be looking into. But I think that's something that a lot of the specialists that I actually even speak to are quite unaware of.
They are, and it's no fault of the specialists. They're not trained extensively and for many years in nutritional biochemistry and, the use of vitamins and minerals and how they function for medicine in the human body, where that is the naturopath's training. So the integrative approach is so incredibly important. I always work with a medical specialist when I'm helping couples through miscarriage, because there's simply some of the work that I can't do. I can't, do uterine biopsies to see whether there may be immune involvement that's causing a part of the problem. So it's very much a team approach between the medical specialist, a good GP and a naturopath can go a long way to finding many, many parts of the puzzle to get a couple to a healthy baby born.
Exactly. So, we're all working to the same end. I find it really great to work with other specialists, and then luckily in the Conceived Baby website we do have a lot of specialists that are very much about that integrative approach, because we're all working towards the same end.
That's exactly right. All of us want that healthy baby in your arms.
Exactly, yeah. So if we can work together, it's not just about natural or IVF, it's about, okay, what do we need to do on either side, whether it, as I said, be pharmacological or whether it be a naturopathic approach. If we can use the best of both worlds, we can get a better outcome. And particularly when it comes to that folate metabolism, I think that's where someone like a nutritionist or a naturopath can really stand out and go through the differences in the folinic versus folate versus the methylfolates for you and decide which one you actually need.
That's right. And, the MTHFR, piece of the puzzle is also important for your ability to be able to detoxify. So if you're not able to run what we call a very complex biochemical pathway in our body called methylation, which requires folate in its metabolized form, then not only does it affect chances of carrying your baby, but also your body is exposed to more toxicity because it can't clear it properly as well. And that can, that can lead to, potential risks and problems for, the baby being exposed as well. So, just the simplest thing, being on the right type of folate for you can have so many upsides and benefits. And that's, a giant leap in our understanding of our individual genetic makeup. And pharmacy as an industry is going in this way. And I think that, medicine of the future, everyone will do a gene profile before we will know the right nutrients or the right drugs or the right treatment protocols for that individual, which I personally find really exciting.
It's fascinating. Actually, just last webinar actually was with Dr. Natasha Andreadis, and she talked about genetics and personalised medicine and how she uses that genetic profiling in her both fertility and pregnancy patients. So it's really interesting that is the future, and it's an interesting discussion. I think it's becoming more globally recognised and utilised, which is exciting.
Absolutely. And, it's my, hit prediction that I think, when we personalise medicine to that point, we will see incidence of miscarriage in couples decreasing actually, because with genetics in medicine comes a lot more information about diet choices, lifestyle choices, not only the right pharmaceutical choices or nutritional choices, and all of that collates to better patient outcomes in terms of reproductive health capacity. And healthy aging capacity as well.
Exactly, which are interrelated. Yeah, healthy aging, you are more fertile for longer. So there are things that we can do. It's not just about a finite, you need this particular pharmaceutical or vitamin, or about whether it's an age as well. I know there are statistics that, once you are post-30, fertility decreases, but there's a lot of factors that you can actually do to improve your chances and reduce your risk of miscarriage as well.
Absolutely. And for the, the gorgeous girls that come and see me that are, a little bit older, and, I'm post 40, so I, can talk truthfully and honestly about my experience with these women as well. They come in and say, I've had a couple of miscarriages and my AMH is really low, and I'm, am I going into perimenopause? Is this ever going to happen for me? And I say, AMH is only a marker of quantity, not quality. And when we're talking about your eggs and your husband's or partner's sperms, all I'm interested in is quality, frankly, and quality of the integrity of that DNA. Now, it's really fascinating that, I guess, with the advances in reproductive medicine and what IVF has taught us, is there's actually an extension of a sperm analysis that's quite commonly done nowadays, where in addition to, of course, just the sperm count, and the sperm morphology, which is basically the head, body, tail. It's the swimming apparatus for the important bit, which is the DNA, the nucleus. They actually now do a test called a sperm chromatid structure analysis, or it's called a DNA fragmentation index. So 2 terms for the same test, where the scientists can actually unravel that helix of DNA and have a look at how much of it's broken and basically, damaged versus how much is intact. And I find that just mind-blowing that they can do that with sperm, Sydney, Melbourne, Perth, all around the country, and in any first world nation that's a test offered. And one of the most mind-blowing pieces of research that I found when I was collating this information for the book was the fact that a high DNA fragmentation, so a DNA in a man's sperm that's terribly broken beyond 15%, it's the highest predictive factor for a miscarriage.
Wow, that's fascinating that we can find that out. Also, that we know that when women often blame themselves, that there is that large percentage that is blamed in the sperm.
Absolutely. And what I find, quite infuriating is, often couples, preconceptually, or if they've had a miscarriage and they even clue on to looking at the father, is that standard sperm analysis don't include the DNA fragmentation. You have to request it specifically. So 9 out of 10 times it's not done. And a sperm analysis can look okay on the outset, fine in terms of, sperm count and motility and morphology. They can look okay, but you can still see bad DNA fragmentation. So I feel that it's probably one of the most important first steps in the path of understanding the why. Because as I'm sure that every one of us that work in the field of naturopathic fertility management is sperm, generally speaking, is a pretty easy fix. If you clean a man's diet and lifestyle, work on a bit of detoxification, give him fantastic antioxidants, mainly like zinc and selenium and coenzyme Q10 and vitamin C and beautiful herb called polygonum, you can actually vastly improve that DNA fragmentation index and get them back into a healthy range and significantly reduce risks of miscarriage by just doing that work. And you know what? You can achieve that in 90 days, 3 months.
So what is the name of that test, just to make sure everyone's got the name of that test that they should be requesting? They can request that from their GP, is that correct? Or
they can request that from the GP. It does need to be done through a specialist fertility lab and andrology laboratory. So all the IVF clinics have those, around Australia. Yep. So the test is called a sperm chromatid structure analysis, or the alternative name is a DNA fragmentation index test.
Okay, I might put some details of that up on the website too, so people can actually get more details on that. And so I mean, sperm is a really major cause. What are some of the other causes that you do see in women that you treat, and also in your research?
Oh, look, the list is so long, Tasha, and that's what's so incredible. The investigations can be incredibly thorough. So there's genetic factors. We've touched on MTHFR and that genetic polymorphism. Some of the other genetic factors can be things like inherited thrombophilias, and that's just a big term for your body likes to clot blood more quickly than other people's based on your genetics. So these inherited thrombophilias include things like factor V, Leiden, prothrombin gene mutation. The MTHFR is considered one of these as well. And if couples, or the woman is particularly found to have one of these inherited thrombophilias, then basically as soon as she's pregnant, her specialist will start her on a daily little injection. And I know that sounds scary for a lot of women, but it's a teeny tiny little injection, a bit like a diabetic would use, that they give every day through the pregnancy up to a certain point of the pregnancy. That is just a blood thinning agent that is safe for mother and safe for baby, that can reduce the risks of any blood clots forming between mum and bub and result in a healthy live birth. So that might sound like a radical intervention, but there's a lot of good research to show it's a powerful intervention if you carry one of these inherited thrombophilias. Then there's things such as autoimmune fertility complications. And one of the core and primary researchers in this field was an American doctor by the name of Dr. Alan Beer. And he wrote an incredible book called Is My Body Baby Friendly?, explaining all about how the immune system is intimately involved with understanding that you're carrying something foreign in your body, that DNA is different to yours, but is not going to harm you. So your immune system has to do a complete turnaround and behave entirely differently in your pregnancy than it would normally. And unfortunately, some women's immune systems don't do this properly. And they have things like elevated, what we call natural killer cells, which sounds pretty dire, that actually, attack the placental development and can attack the pregnancy because her immune system can't recognise that DNA is actually being okay for survival of life. So again, for these types of problems, specialists will generally, if it's discovered, they will recommend a course of very low dose steroid therapy to suppress the immune system, quieten the immune system down, and just ask the immune system to not be so on the attack, so to speak. So again, that is a pharmaceutical intervention, but one that can really actually change lives and create families at the end of the day, if that particular issue is discovered. And there's a lot of naturopathic support we can do behind the scenes to help reduce the side effects of the steroids and help her body cope with them better without interfering with their effectiveness along the path. Then there's infection. Basically, there's a number of different infective organisms that can lead to miscarriage. And these are types of infections that can cause damage to the growing and developing baby and the baby's life lost as a result of that. Other infections can cause rupture of the amniotic membranes. So generally, about 50% of these infections that are known to be associated with miscarriage or problems with the baby's development are generally checked preconceptionally, but 50% of them are not. So in my preconception, testing protocol that I, get couples to do, I get them all tested for, because again, it's very simple intervention pre-pregnancy to clear one of those infections, be it with some natural medicine or with an antibiotic, and back up with good probiotic support after that, of course. So that's a very easy tick in the box to support if infection's involved. Then one of the big ones is hormones. Our hormones are incredibly complex. I always say hormones are like a symphony orchestra. If one instrument is ever so slightly out of tune, it affects the sound of the whole system. So when it comes to miscarriage, we do know that insulin resistance actually quite significantly increases your risk of miscarriage, even if everything else is perfect. And insulin resistance is that step before diabetes, where the fasting insulin is above 10 on a blood test. Now, any GP will run that for a woman. Often that'll be accompanied with, common female hormonal conditions like polycystic ovarian syndrome, or not even having the syndrome, but just being overweight and your diet not being optimal for conception and pregnancy. And I've had a case recently that was an alarming example of this. She'd unfortunately lost 2 babies between 18 and 22 weeks. So, that's getting significantly on in that second trimester, of course. And when we did the thorough workups and investigations, the only thing we found was insulin resistance, but her fasting insulin was up to 25.
Wow, we're unaware of that, obviously, before you tested her.
Yeah, absolutely. And she obviously came in extremely distraught and so incredibly grief-stricken to have lost 2 babies, at that stage of a pregnancy, and she kept saying to me, they've done all the tests and they tell me everything's okay. And I held her hand and I reassured her and said, we will find something that we can manage to give you more confidence that you're doing something differently going into your next pregnancy. So, she worked really hard. She started eating immaculately, doing personal training, managing her stress and doing guided meditations, and lost about 20 kilos, which completely has corrected her insulin resistance. And she's just about due. She's 38 weeks pregnant, waiting for her little baby to finally arrive.
Oh, isn't that wonderful? It's always great to hear those success stories. And I think that's a good indication of why weight is not just an issue because you're obese. And we see the statistics. You're less fertile and you're more likely to miscarriage if you're obese. But giving us an answer to why, which is, I find, really motivating for someone too. What doctors often send you, okay, you need to lose weight. But why and how, I think, are often the questions that aren't answered by some of the specialists.
Absolutely. And one of the things that I do with every patient who needs to lose a bit of weight, whether it's PCOS or, fertility, pregnancy related, is I actually get them to go and see an exercise physiologist to design them a specific exercise program that suits them, that is manageable for them as an individual. And then I will see them as often as they need to feel supported and to make sure that then they don't feel alone on that, weight loss journey per se.
Yeah.
And the smallest changes can make the biggest impacts as well. So simple things like, maybe just cutting out bread can make a really big impact on your weight management, your blood sugar levels, your insulin levels, and it might not seem like a massive change, but it really can be.
Especially helping those cravings. I know insulin resistance is hard to overcome if you don't know the dietary strategies to apply, because you do get those cravings, and it is hard to just simply stop eating, or some people just try to, just stop eating for a while or reduce what they're eating dramatically will not help insulin resistance. About eating the right food at the right times. So speaking to someone like yourself, we've got information on the website as well, and getting the correct advice as to what type of diet to use, not just restricting your intake generally.
Absolutely. That's absolutely correct. One of the other, sort of hormone/immune issues that has a big incidence of increasing for miscarriage risks is thyroid complications. And generally in a preconceptual screening with a GP, they might just check one factor, and that's thyroid stimulating hormone. Now, that's only one part of a complex puzzle when it comes to understanding the thyroid's role in reproduction. And the thyroid pretty much is one of the major hormones that drives cellular replication and hormone production, and is so critical all through pregnancy, but particularly in trimester 1, because the baby relies on mum's thyroid hormones in trimester 1 until the baby's actually grown a thyroid and the baby's thyroid starts functioning for itself. And one of the things with thyroid that gets missed all the time is checking for thyroid autoantibodies. And it's amazing that, the research is there. It's not my opinion that women may have what we call euthyroid, or perfectly normal TSH, free T4 and free T3. They're the major things that are checked for, but they may be positive for thyroid antibodies. They have a much higher statistic for miscarriage. Now, what can drive thyroid antibodies? Well, again, it can be genetics and a family history of a condition called Hashimoto's. So ask your aunties and your mum and your grandmother and your cousins, about these types of things. I think women in families, we need to have more frank health conversations, because we're gathering a genetic pool of information about ourselves then. But the things that can drive thyroid antibodies are genetics. For some individuals, it can be overexposure to gluten or casein, which comes from dairy milk. In other people, it can be good old-fashioned stress, or naturopathically, we refer to that as cortisol. And if patients are driving, that stress response, and their body is just a fountain of the stress hormone cortisol, that's been known to trigger autoimmune disease in some genetically predisposed individuals. And then there's even gut bugs like Blastocystis hominis, Klebsiella, that have been linked to the stimulation of autoantibodies, but particularly Hashimoto's as well. And most people, when I start talking about this, say, well, I don't know that I've had a gut bug, that's fine. But we know it's actually in Sydney water supply, for example, and up to 20% of the Sydney population test positive for Blastocystis hominis and don't even know they've got it.
Wow. I think we do often, we sort of take advantage, don't actually take notice of digestive symptoms these days. It's also bloating, heartburn, or we do ads on TV, just take antacids, or it's almost the norm that sort of symptomology is what you should just accept. But it may be recognition of an underlying condition, such as what you described.
Yeah, absolutely. So, the investigations actually do run pretty deep, and, some women say, remind me again why you're making me do a stool test for my miscarriage risk. So I generally do a lot of mapping out of, okay, we've found thyroid antibodies. Now I need to understand why in order to make sure I can get you on the right path. So the question that I never stop asking, Tasha, is why?
Yeah.
This has come up positively. Why? When we find the answer to that, we dig deeper and ask that question again and again and again and again until we get that baby in the man and woman's arms.
And I hope that this type of information that we are giving to people today can give them the confidence to keep asking why. I think once you are told by your fertility specialist, as we've often said at the start, that, look, these things happen, here we go, we'll try your next cycle again, often with little further involvement of the specialist other than that. I mean, there are a lot of specialists that aren't taking the time and actually understanding. But as a generalisation, people are getting that information. So encourage them to ask why themselves. It doesn't just have to be told by your specialist. Feel free to inquire by your specialist. If you're not happy with your specialist's opinion, please go see Angela, or another specialist. Get a second opinion and keep asking why, because it is your life and your baby, and no one is more invested in it than yourself. I know I love hearing the outcomes that, as you described, Angela, and nothing makes me happier than to get the email saying that people's pregnant, or that they've actually conceived after so many miscarriages. But ultimately, the one that's most invested in that pregnancy outcome is yourself. So I love the fact that you keep asking why, and I'll encourage more people to ask why as well.
Absolutely. And one of the big questions I get asked by every lady that comes and sees me who's experienced miscarriages, I've had a miscarriage last cycle, how long till I can try again? And my answer to that question is the same every single time. And I say, as long as it takes for us to get all the information required, fix up any problems we may find, so that both you and I are confident that your next pregnancy will be a full-term pregnancy. So generally speaking, that is going to be around about 3 to 4 months, so that we can invest a month in thorough investigation, understand the problems, and have proactive intervention in place so that we know all the bases are covered, and then allowing your body some, recoup time from, an emotional, a physical, and a spiritual standpoint to prepare for that next little baby that will be growing in your body. To be pregnant in full term is extremely extremely hard work for a woman's human body, but a lot of the nutritional reserve is really used by that little baby growing in the first trimester. So even if you've got to, 6 weeks in a pregnancy and lost that baby, your body has used 6 weeks worth of reserve to grow that little baby to that point. And as you can imagine, if you get on to more like 10 or 12 or 14 or, later in the pregnancy as an osteo baby, your reserves have dropped quite a lot. So I am very passionate about encouraging repletion, emotional repletion, spiritual repletion, to really prepare on all levels for the next pregnancy. It's so important to the outcome.
That's a great answer there, and I think it's what many women want to hear. And I think it's not just about, okay, you're not allowed to try for this amount of time, because there's a lot happening during that time. It's not as if you're just sitting back and waiting for a certain period. There are so many things. You're proactively changing things in your diet, as you said. We're looking at the male factors, doing your testing, so you are actually on your way to pregnancy, because you're still nourishing that baby. You are still nourishing that DNA that has the potential to become your future baby. So, right, often people say, oh, I don't want to wait that long. And you're not waiting. You are already nourishing your child, so that when that actually egg and the sperm does come together, you are more likely to have a viable pregnancy. And it's not just about the viability of the pregnancy, as you know. I think it's about determined to get pregnant and have a healthy baby. It's about that baby's life. The more preconception care that we can do now, and I love working with fertility people, and really prior to pregnancy, is you're creating a healthy baby for the longer term. And as you would know, research is now suggesting that the nutrition you provide prior to conception can have a greater impact on the long-term health of the child than actually their genetics. You can actually switch on and off genetics, which I've actually discussed in another webinar as well, during that preconception period. So see it as a positive as much as you can, that waiting period. And you are doing so much in that period that it's not just about us sitting back and waiting for 3 months.
Absolutely.
Well, thank you so much for your time today, Angela. I know it's been a whirlwind for you, and I really appreciate you taking the time, since you have just come off lecturing, and the information you've provided today is really fascinating for myself, as well as I'm sure everyone out there. So thank you for your time. And if anyone would like more information and speak with our specialists in our series, jump on conceivebaby.com.au and make sure you join our community and receive our updates on our next expert guests, and also our regular articles on the website. Thanks very much for joining us.